the maternal prognosis? So these two are the most important points. Maternal prognosis, fetal prognosis. How does it affect the mother? How does it affect the child? Atopic eruption of pregnancy has no maternal risk. Even when you go for referrals, you should be very clear with regards to the prognostic markers of both in the mother and in the baby. Polymorphic eruption of pregnancy, no maternal risk. You have to reassure the mother. ICP, yes, there is a risk of preeclampsia, gestational diabetes, postpartum hemorrhage, premature labor, stillbirth. You will be careful about these. Pemphigoid gestationis, the overall prognosis for mothers is good, with most cases resolving within weeks or months after delivery. So, it will tend to spontaneously regress once the baby is out. The mother, however, may be at risk of developing other autoimmune conditions like Graves' disease, because ultimately it is an autoimmune disorder. So, she is definitely at risk of developing other autoimmune conditions. Pustular psoriasis of pregnancy, yes, this has maternal risk. It can be associated with a low calcium electrolyte imbalance, which can lead to seizures, tetany. Maternal convulsions may occur due to elevated calcium levels also. Fluid losses, dehydration, sepsis, because the skin has gotten infected once the pustules ruptured. What about fetal prognosis now? How does it affect the baby? Atopic eruption of pregnancy, no risk to the fetus. Polymorphic eruption of pregnancy, again, no fetal risk. Intrahepatic cholestasis of pregnancy, yes, there is a risk of prematurity, respiratory distress, meconium staining. Stillbirth is an additional fetal risk, especially when the bile acid levels were more than 100 micromoles per liter. That is why the recommendation is to get the baby out at 36 weeks. As soon as the lung maturity is achieved, you get the baby out because you don't want to risk a stillbirth. Pemphigoid gestationis can be associated with fetal growth restrictions, so preterm, small for gestational age babies can be born. Neonatal pemphigoid gestationis may occur in up to 10%. So, out of every 10, one baby can get it. But this mild blistering usually resolves spontaneously. So, even in the mother, it resolves spontaneously after delivery. Even in the baby, it is seen to resolve spontaneously. What about pustular psoriasis of pregnancy? It has a risk of the children getting preterm deliveries, neonatal demise. So, stillbirths can be there. Fetal growth restriction. PROM can occur, premature rupture of membranes can occur, and intrauterine fetal death due to placental insufficiency. So, this is one of the more dangerous pregnancy-specific dermatoses. Now, I am here going to summarize all of them so that you can easily be able to differentiate between these. Pustular psoriasis of pregnancy is very characteristic. It does not usually come as a differentials of these because it would have erythematous plaques started with pustules, inflexures, with probably the patient may be having a history of psoriasis. So here we are going to be differentiating polymorphic eruption of pregnancy, atopic eruption of pregnancy, pemphigoid gestationis, and intrahepatic cholestasis of pregnancy. The frequency of PEP and AEP is higher, they are more frequent. Pemphigoid gestationis is rare. Intrahepatic cholestasis of pregnancy again is more common than PG but less common than atopic eruption of pregnancy and PEP. The onset of AEP is the earliest in the T1 or early T2. All the others are going to be occurring in the third trimester or rarely in the late T2. Association with primi gravida is there in the polymorphic eruption of pregnancy. Similarly, association with multiparity is also there in polymorphic eruption of pregnancy. Also there in intrahepatic cholestasis of pregnancy. Clinical features. In the polymorphic eruption of pregnancy, there will be urticarial papules and plaques which would start in the abdominal striae. Atopic eruption of pregnancy will be E-type, which would be eczematous eruptions. P-type, which would be pruritic papules, nodules or prurigo on the extremities and trunk. Pemphigoid gestationis would occur as vesicles and bullae on an erythematous base or without an erythematous base with a prior history of urticaria can be there, and it will involve the periumbilical area. Intrahepatic cholestasis of pregnancy, again no primary skin lesions, mostly just intense itching, especially on the palms and soles. So, with clinical features, polymorphic eruption of pregnancy would present with urticarial papules and plaques which would start in the abdominal striae. Atopic eruption can occur as eczematous lesions or it can occur as a prurigo. So, there will be eczematous rashes on the face, neck, trunk, or there can be small pruritic papules or nodules on the extensors and the trunk. Pemphigoid gestationis would have vesicles and dense vesicles and bullae on an erythematous base, and they may be preceded by urticarial lesions, and importantly they will occur in the periumbilical area. Intrahepatic cholestasis of pregnancy, there will be no primary skin lesions, there will be just excoriations, and the patient would have intense itching, especially on the palms and soles. Pruritus, they are mostly pruritic, only pustular psoriasis of pregnancy is the one which is not pruritic. The sites striae in the PEP, trunk, extensors, almost the whole of the body in atopic eruption of pregnancy. Abdominal, especially periumbilical lesions in pemphigoid gestationis, and palms and soles, later the rest of the body also in intrahepatic cholestasis of pregnancy. Family history can be there in polymorphic eruption of pregnancy and atopic eruption of pregnancy, since family history of atopy can be seen. Family history can also be seen in intrahepatic cholestasis of pregnancy. Diagnosis is usually clinical in atopic and in polymorphic eruptions of pregnancy. However, a biopsy is recommended in pemphigoid gestationis and also in intrahepatic cholestasis of pregnancy, where you should be doing a bile acids levels. Maternal risk is not there in both PEP and AEP. It is there in pemphigoid gestationis. The patient may continue to progress to bullous pemphigoid, might have other autoimmune conditions. Even in intrahepatic cholestasis of pregnancy, icterus, gallstones, other disorders limited to the biliary system can be present. Fetal risk is not there in PEP and AEP. It is there in pemphigoid gestationis in the form of prematurity, small for gestational age birth, neonatal blistering, which is of course transient but may occur. And even in intrahepatic cholestasis of pregnancy, premature birth, fetal distress, stillbirth is possible. Is there recurrence of PEP? Usually no. AEP, yes, may recur, since the patient, if it is atopic, may recur in subsequent pregnancies. Pemphigoid gestationis, yes, even with oral contraceptives, recurrence can occur. Similarly, intrahepatic cholestasis of pregnancy, yes, even with oral contraceptives, it may recur. Treatment of PEP is with steroids, antihistamines. Even of AEP, you would just give steroids and antihistamines. Pemphigoid gestationis, oral steroids usually would be needed in a dose of say 0.5 milligram per kg. And intrahepatic cholestasis of pregnancy, ursodeoxycholic acid is the drug of choice. So this is just to summarize and to give you a differential of all these 4 important pregnancy dermatoses.